That's all right. I'm just gonna start by just going over the syllabus real quick, just a formality. Um, so we are now in Echo 213, our final Echo class. So this class is going to be comprised of 3 quizzes, a midterm, and a final. We'll also have 3 lab competencies. So this semester, we're going to discuss fetal embryology and fetal circulation, and then get into congenital heart defects, as well as some repairs for the congenital heart defects. We're going to have a lecture on stress echocardiography and other diagnostic procedures. So that's going to include like the nuclear stress test, Holter monitors, some of the catheterization procedures. We'll have our midterm exam, which will cover, that's just going to be the congenital heart defects and the embryology for the midterm. In between those, I'm going to have actually take-home quizzes. So I'm going to have a bunch of questions, question packet for you guys to work on at home. For me, it's more important for you to kind of like search and dive into it and find the answers to make sure they're correct, and rather just giving you guys a, like a 20-question quiz here. I think it's more beneficial if you're actually like researching and looking up the answers, making sure they're all correct. In terms of our labs, I was going to start with aortic valve calculations. So, properly measuring LVOT, velocities through the LVOT to calculate aortic valve orifice areas. Equations that we'll use, we'll become familiar with the continuity equation. We'll also become familiar with mean pressure gradients for when we have to determine regurgitant values. We'll also then follow that, get into mitral valve calculations. So that'll include your PISA, as well as pressure halftime. So we'll be practicing those in the lab. So then we'll also get into the tricuspid and pulmonic valve calculations. So that's also going to include measuring, assessing the right ventricle, like some of the tissue Doppler measurements that we do for the right ventricle as well. So our comps will be for the aortic and mitral valve calculations, and then the tricuspid and pulmonic and pulmonary vein. So the Doppler and calculations that we do for those things. Then we'll have a lecture on diastolic dysfunction. And then we're going to I wanted to focus the end of the semester on really getting into cardiac pathology images and really being able to look at images and diagnose pathology. So since this is going to be like essentially our last echo class, I feel we really need to get strong on just being able to assess an image and figure out what's going on and diagnose the pathologies. So I'm going to spend the last couple of weeks just focused on that, going through lots of images and case studies. Week 7 in lab, we'll introduce our non-imaging PDOF probe. So we'll get our hands on that, play around with that. There are 2 lab classes that I actually had to move to Thursdays because of holidays, because we didn't have class. So on that week of July 4th, they give us off on Monday, since the holidays on Sunday. So I just moved up. We're not going to have lecture, but I just moved our lab to the 8th. And then on Memorial Day, I moved our lab to that Thursday as well. So those are the only 2 days that we'll have the lab on Thursday. So with that, like I was gonna, we were talking before, we could move that scanning applications lab to today, to Mondays, to kind of just get it all done in one shot since we're here. So to free up some more time. So we just have that lecture on Mondays. But those were the only 2 Thursdays that I was gonna have you come in for the labs. Just because we're missing that that week. So then
I'm cool with that. I don't.
Yeah.
Either way.
Is everyone on board with that? Is that okay?
What is, I mean, I guess you'll tell us what it is, but like, is it just like scanning practice, like an extra hour of?
Essentially, yeah, the scanning applications class for us, we have 3 or 4 comps. I think it's 4 comps. We have another carotid comp, a lower extremity DVT comp, a reflux comp. And then I'm trying to think of one more, like what would be good for us to practice if we should go back to like an extremity arterial or maybe like an upper extremity PVR, something. We could figure that out. Like that would be our 4th one for the scanning applications class, whatever we want to like focus and practice on that we feel like we need the most help with. But we definitely have to do a reflux, a venous reflux, because we haven't done that. That's for the scanning apps class.
Okay, cool.
And then for our class after the PDOF, we'll get into some of the biplane Simpsons, so measuring systolic function, and then as well as atrial volume measurements, what measurements we need to take to calculate atrial volumes when we trace the atria. And then we're gonna put it all together and practice a complete echo from A to Z. And then your final comp would just be performing a complete echo. So hopefully by this point, we'll all feel pretty comfortable. So this summer is just going to be a lot of scanning. Like Monday is pretty much like after this lecture, you come in and we're just going to scan all day. And if the DMS girls also have off today. So if you want to invite any of them in, if they're so willing to be our models, I mean, I'll reach out to them too, see if anyone wants to volunteer during the afternoons to come in and allow us to scan them. That would be great. When you
Yeah, Kristen has really good
yeah,
pictures, apicals and subcostal.
yeah. I'm just, as I go, I'm just going to be updating this course outline with some of the reading assignments as we go along. This cardiac embryology module is on D2L. It's a separate little tab that has good videos over here for the cardiac embryology. It was a nice website that had like animated videos that were voiced over for all the different cardiac embryology stages. This was pretty helpful, I found. Righty.
Will we get to like practice fetal echoes?
So yes, starting in the fall, we're going to actually, you're going to be having rotation going through AI through the pediatric
Cool.
echocardiography lab. Yeah. So yeah, so you'll get some exposure to that, definitely. Which is nice because I know the graduating class didn't have that opportunity because of COVID, but they're opening it back up to us now, starting in the fall. Alrighty. So our topic today is going to be cardiac embryology. So cardiac embryology begins with a primitive heart tube. So the initial heart forms as a tube which is going to align itself from from cranial to caudal. It begins as a primitive heart tube, a pericardial cavity that is composed of the sinus venosum, cardiac loop, and the bulbus cordis, which is also a component of that is the truncus arteriosus. The embryonic heart appears about week 3 in gestation. At about week 4, the tube will rotate 180 degrees to form the atria, ventricles, and the truncus arteriosus. and blood flows through this tube in single direction. And then by about 7 weeks, the heart is completely functional. Another thing I noticed too in some of the literature is this initial heart tube, when it starts beating, it has an initial heart rate of only about 60 to 70 beats per minute, which may seem pretty low. And I remember one of the DMS girls was talking about a study that she did at the clinical site where I guess the technologist measured the fetal heart rate and said that it was very low and this was likely a fetal demise. And then she came back and, a couple of weeks later and everything was fine. The heart rate was at a normal rate. So they were probably just measuring this early fetal heart, this heart tube, and got, like maybe 75 beats per minute. And we're like, oh, this is not good. This is too low. Not realizing that that's actually normal for an early developing heart. And that heart rate's actually going to accelerate and reach an approximate value of about 130 to 150 beats per minute. This shows the endothelial tubes. So these tubes will come together and fuse at day 20. And the heart tube then will consist of 7 regions. There'll be the sinus venosus. This is going to be the venous portion of the heart. The primitive atria. You'll have a AV or atrioventricular canal. Your primitive ventricles. The bulbous cordus. The truncus arteriosus. And the aortic sac and arches. This is a picture at about week 3. So down here you have your sinus venosus. So this is going to be the blood flow coming into the tube. Your atria, primitive ventricles, bulbous cordus, and the truncus arteriosus, which is going to develop into your aorta and pulmonary artery. If you notice from this picture, you have the atria on the bottom and ventricles above it. So the sinus venosus develops from the umbilical vein and the vitelline veins and is caudal in position. The right and left sinus horns respectively develop from these veins, and the right horn develops the vena cava. And the primitive atria, they're divided equally by the intraatrial septum, which is composed of the septum primum, septum secundum, and the foramen ovale. So the atrioventricular canal, that's going to be a large communication between the primitive atria and the primitive ventricles. The endocardial cushions. So I'm going to describe that in just a moment. The endocardial cushions, those become our big players when we're talking about ASDs and VSDs. The endocardial cushions will divide the AV canal into 2 AV orifices or openings. And they also contribute to the closure of the ostium primum portion of the atrial septum and the membranous section of the ventricular septum. The endocardial cushions are also responsible for the formation of the anterior mitral valve leaflet and the tricuspid valve septal leaflet. Complete absence of the endocardial cushions will result in a complete atrioventricular septal defect, which is a common finding in Down syndrome. 40% of Down syndrome patients have this defect. Now we have the primitive ventricles. Normally, this is a morphologic left ventricle that shifts to the left during development and is eventually divided by the intraventricular septum. 80% of all univentricle hearts are a morphological left ventricle. The bulbous cordus forms the primitive right ventricle and the ventricular outflow tracts, also called the conus cordus. The conotruncal abnormalities include persistent truncus arteriosus and tetralogy of Fallot. The truncus arteriosus contributes to the formation of the aortic and pulmonary artery trunks, and failure of the truncus to divide will result in persistent truncus arteriosus, which is a single vessel, comes out of the right and left ventricles instead of separating. It's another picture of your primitive heart tube. So if we go back, you see over here, this area, the aortic sac. So that's going to develop. And within that sac, we have 6 aortic arches. So when we're talking about the number for the aortic arches, the first pair is going to be more superior or more cranial, and the 6th pair is going to be more caudal. So the first pair persists as components of the maxillary arteries and the external carotid arteries. Second pair persists as the stepetal arteries. The third pair becomes the common carotid arteries and the proximal segments of the internal carotid arteries. Fourth pair, right, becomes the most proximal segment of the subclavian artery. Left becomes the aortic arch segment between the left common carotid and the left subclavian arteries. Fifth pair are just rudimentary. And the 6th pair becomes the proximal segment of the right pulmonary artery. The distal part disappears early. The left becomes the proximal segment of the left pulmonary artery. And the distal part persists until birth as the ductus arteriosus. So in terms of probably the registry exam, I would remember the third. You may get that, and I might also potentially be a vascular question. The third pair of aortic arches becomes the common carotid and the internal carotid arteries. For sure, the 6th pair develops into your pulmonary artery, and the 4th pair of the subclavian and portion of the aortic arch. So 3rd, 4th, and 6th. So this is just a picture now showing your alignment of your aortic arches within that sac. So 1 is up high, 6 down low. So those become your pulmonary arteries. These would be your external carotid arteries. And this kind of just shows the formation, goes through the formation of them, has a split and branch, become the various structures that they become. And another diagram demonstrating the development of the arteries. So when we get into embryology, we begin with our early heart tube. And that heart tube is going to begin a process called cardiac looping. So it's called S looping. So the S loop is broken down actually into two criteria, I want to call them. So normal looping is known as D-looping or dextro looping. And with D-looping, the heart tube moves anteriorly and towards the right, creating the bulbar ventricular loop or tube. We can have malrotation of that heart, which we'll get into a little bit later. That's called L looping or levo looping. So with D looping, this signifies that the atria will be joined correctly to the ventricles. The morphologic right atria will be connected to a morphologic right ventricle, and the morphologic right ventricle is connected to the pulmonary artery. The morphologic left atria will be connected to a morphologic left ventricle, and the morphologic left ventricle will be connected to the AV, aortic valve. This is known as concordance. So if the heart tube loops anteriorly and to the left, as opposed to the right, this will result in intraventricular inversion or L transposition. The morphologic atria will be connected incorrectly to the ventricles. So this is considered atrioventricular discordance. So what that means is the right atria is then going to be connected to the left ventricle, and the left atria will be connected to the right ventricle. Septation. So it is a complex stage of development that begins at approximately 27 to 37 days and is completed by the 5th to the 6th week of gestation. It consists of the development of endocardial cushions, AV canal, and the truncus region. So atrial septal formation. The septum primum extends downward from the atrial roof to merge with the ventricular septum as it extends upward from the anterior wall of the common ventricle to form the endocardial cushion. The septum secundum develops from the septum primum on the right side, but does not extend to the endocardial cushion. The foraminal valley remains open in utero. The right atria grows larger, and in the left atria, the pulmonary veins form from the atrial wall. Oh. I drew this little picture to kind of understand a little bit better the septal formation. So at this point, the hearts began to loop. So we now have a more orientation that we're able to recognize with the ventricles on the bottom. This is your primitive ventricles. And your primitive atria. These bright circles in the middle here are your endocardial cushions. So as your septum start to develop, in your atrial septum, this is going to be your septum primum. So primum first, primary. So what's going to happen now is from these endocardial cushions, your septum is going to start to grow up and grow down, and they're going to meet. So your septum is going to start forming from your endocardial cushions. And you're going to have a hole between the septum and the atria. And this opening is going to be your ostium primum. So ostium is going to be your opening, primum, your first opening or primary, first to develop. And as we move along in development, a second septum is going to form on the right atrial side, coming down. And this becomes your septum secundum. Your second septum. So now when that septum develops down, we now have a channel from the right atrium into the right left atria. So this opening here now becomes your foramen ovale. And this channel now becomes your ostium secundum. So while that's going on, you also have development of the ventricular septum. So the portion that's growing down from the endocardial cushion is thinner than the portion growing up from the base of the heart. And this thinner portion is the membranous intraventricular septum. So it's the membranous section of the intraventricular septum. While this is happening as well, those endocardial cushions are growing outward also to form our AV valves. So in the primitive heart, that channel between the endocardial cushions is called the AV canal or atrioventricular canal. So this large hole over here is the sinoatrial orifice, which is going to be the location of the eustachian valve. So septum primum, septum secundum, the channel between the septum secundum and this portion of the septum primum is your foramen ovale. This hole now becomes, once that developed, the ostium secundum. The endocardial cushions also go down, and the ventricular septum comes up to meet it. The thinner portion of the ventricular septum is the membranous portion of the intraventricular septum. The endocardial cushions also help to form the atrioventricular valves. So intraventricular septal formation. The intraventricular septum is formed by the swelling and moving together of the endocardial cushions and the muscular floor and the conus cordis. So the endocardial cushions located at the crux of the heart, that cross, forms the uppermost or membranous portion as it forms from the inferior aspect of the heart. At the same time, the muscular floor grows superiorly towards the cushion and makes up the muscular portion of the intraventricular septum. The conus cordis, which is cephalid, swells inferiorly and contributes to a lesser degree to the mid portion of the septum. So the intraventricular septum is completed between 55 and 65 days in utero. So this just kind of again goes through that formation of the septums. So your septum primum, your ostium primum is that initial hole between the two atria. Your endocardial cushions. So then as you have development of that endocardial cushion growing up, in your septum primum, your septum secundum is developing. You have that hole now becomes the ostium secundum, or the secondary hole. You have further development of the septum secundum. And then you wind up with the foramen ovale, kind of that channel between the ostium, I'm sorry, the septum primum and the septum secundum. So when, the child takes that first breath and we talk about the foramen ovale closing, it's these two septums that get held together by the difference in the pressure. So this ostium primum slams against the ostium secundum and maintains a closed foramen ovale. You can also see the ventricular septum, the muscular portion, and then the membranous portion, which grew down from the endocardial cushions. All right, so the AV valves, the mitral valve and tricuspid valve, form from the partitions of the AV canals as connective tissue, endothelial layer, and the muscular cords from the endocardial tissue. The semilunar valves form from the truncus arteriosus as swelling of the mesenchyme that develops at the wall of the aortic and pulmonic channels. The mesenchymal cells form connective tissue, blood vessels, and the lymphatic system. The right and left ventricular outflow tracts form as the truncus separates. So this next slide shows the formation of our great vessels from that truncus arteriosus. And it results from a twisting and a separation within the truncus of the two great main vessels. So you get your conotruncal swelling. So basic embryology, week 3, the heart is a primitive cardiac tube. The cardiac loop forms, the atrium ventricles are in position, and the heart begins to beat, and septations begin. By week 6 to 8, the chambers are completed. By week 7, the heart resembles an adult heart, with the exceptions of the foramen ovale and the ductus arteriosus. So this just shows the three segments, the morphologic atria, valve, and ventricle. So we can also have situs solitus, which is our normal orientation, where we have the right atria on the right, left atria on the left, liver, spleen, normal orientation. You have situs inversus, where things are flipped. Your right atria is now on the left side, left atria on the right. Liver and spleen are shifted, and your aorta and IVC are inverted as well. Or patient could potentially be situs ambiguosus, which we can't really determine, which is the right, which is the left atria. The organs kind of just sit midline. So we can't really determine if liver's to the left or to the right. Here again, situs inversus is just a mirror image of what our normal anatomic orientation should be. So this is L looping. This is a folding pattern that lands the right ventricle to the left of the left ventricle and is seen in congenitally corrected transposition of the great arteries. So these would be some views from our postnatal short axis, our normal orientation. And then if we have situs inversus, our pulmonary arteries coming on the opposite side of the heart. So fetal and postnatal circulation. With fetal circulation, the exchange of oxygen and carbon dioxide occurs in the placenta. The oxygenated blood returns to the fetal heart via the umbilical vein. The ductus venosus delivers blood to the inferior vena cava. The eustachian valve directs blood flow towards the foramen ovale. The foramen ovale allows the shunting of blood from the right atria to the left atria. And the foramen ovale and the ductus arteriosus remain patent until shortly after birth. The only small portion of fetal cardiac output flows through the pulmonary arteries to the lungs because pulmonary vascular resistance is greater than systemic resistance.
Then a question. So in the fetal circulation, the blood not going to right ventricle at all, but it goes to the left ventricle, right?
It goes to the left ventricle. Some blood flow does get into the right ventricles. I mean, because it's entering the right atria. Not all of it is getting shunted, through the foramen ovale.
Mm-hmm.
So blood flow is entering the right ventricle, just it's a small amount. Just because the pressure is greater within the lungs at that point. So blood flow is going to want to go into the to the left side of the heart, just due to that pressure difference. But blood flow does have to get, into the right side of the heart and to the lungs to help develop the lungs itself. But the
Okay,
majority-
so
yeah,
then it goes to lungs through the right ventricle.
And the pulmonic valve, it does. I mean, some blood flow does get to the lungs, but the significant amount of it is shunted.
Mhm.
So the majority of the blood that enters the right atria goes into the left atria via the foramen ovale. Because the lungs are deflated in the fetus, therefore there's high resistance in the pulmonary vasculature. The ductus arteriosus shunts blood right to left from the pulmonary artery into the aorta. Deoxygenated blood returns to the placenta via the two umbilical arteries. What happened? What am I doing? So this is just a diagram of our fetal circulation. The blood flow coming in the pulmonary umbilical vein, through the liver, through the ductus venosus, into the IVC, which enters the right atria. Blood is then primarily diverted through the foramen ovale into the left side of the heart. Blood that does enter the right ventricle gets pumped through the pulmonic valve into the pulmonary artery, which a portion of it also gets shunted through the ductus arteriosus into the aorta as well. So blood flow on the left side of the heart is able to travel into the aorta. And then blood flow is then returned back to the mother via the umbilical arteries to the placenta. So postnatal circulation. The umbilical vein is occluded. The lungs inflate, dropping the pulmonary vascular resistance. Systemic pressures rise and blood flow to the right atria decreases. The umbilical vein becomes the ligamentum teres in the liver. The ductus arteriosus closes, becoming the ligamentum arteriosum. as systemic pressure rises above pulmonary artery pressure. The foramen ovale closes and becomes the fossa ovalis as the left atrial pressure exceeds the right atrial pressure. The right ventricular and pulmonary artery walls decrease in thickness, and the left ventricular walls increase in thickness. The ductus venosus closes due to decrease in the blood flow across the vessel and becomes the ligamentum venosum. Go back to your chart with the septations. You kind of picture now pressure higher in the left atrial over here is going to force that septum primum up against that septum secundum, closing that foramen ovale. So that connection between the two. So the increased pressure is what's pushing that septum up against the septum secundum and thus closing that foramen ovale. And this is just a diagram showing our normal cardiac circulation. Which we should all know by now. Thankfully, on the registry, there's not too much in terms of like the embryology. And for what the girls told me, there's a couple questions, you know, about PFO and foramen ovale and the development of the septums. When we get into the congenital heart defects, we'll talk more about the D looping and the L looping and the defects that can result from malformations in the L looping. Does anyone have any questions about anything? No? It's not gonna let me play it on here. Boo. Pretty much it for the embryology. No one has any questions, you know, we're okay.
Thank you, Dan.
You're welcome.
What a
I have a
magical
question.
chapter.
Sure.
Ductus arteriosus, if it's not closing, it becomes a congenital defect, right?
So yes, a patent ductus arteriosus, I guess technically, it's not really a, it's not really a congenital heart defect, like say like an ASD or a VSD. Because it was a normal structure that formed. But it does need to be corrected if it's, you know, remains patent. So I mean, they will go in and close it. So I guess in a sense, it could technically be a congenital heart defect, in a sense. But yeah,
I mean, basically everything that is not closing after fetal circulation, they're gonna surgically fix it after birth.
yeah, I mean, a PFO, a lot of patients don't even realize they have it, to be honest. I heard I've heard some studies up to almost 20% of the population is walking around with the PFO and they don't even know about it. I don't know, that seems a little high, but but yeah, I mean,
Yeah, if it's not causing like severe symptoms after birth.
yeah, you'd never know
Mm-hmm.
unless you have like, you know, a cardiologist that hears her, or, you know.
Okay, thank you.
You're welcome. I will see you guys all a little later this afternoon.
And it's 12
12, yep.
or 1 o'clock.
Oh, no, yeah, 1, right? 1.
It's 1 o'clock.
I thought it was 12.
12, 12. All right, 12.
Okay.
You want to come 12? Finish early and early.
I just confused. I mean, I didn't check the schedule, so it's supposed to be 12, right? Right, girls?
1.
I thought it, I don't know. I can look real quick if you hold on.
Thought lecture was like supposed to be like 4 hours or something crazy, like they gave us.
Yeah.
Lectures 8, 9, 10. Oh wait, maybe it is 12 and we get there. I don't know. Hold on.
I think it's 12 and you get here at 1. But if you want to come 12, that's fine.
Yeah, yeah. Let's do it 12. Maybe we will then skip the rush hour. I mean,
Okay,
in
I
the
can get-
afternoon. Okay.
Yeah, I can get there at noon.
Yeah, let's
And
do
are we
that.
gonna like do scanning applications today too?
Yeah, scan applications was just practicing carotids. That was going
Oh.
to be the first comp.
Cool means.
Yep.
So see you guys at noon.
All right.
All right. See you later. Thank you.